So my name is Conor Price. I work for Wye Valley Trust, but also across Herefordshire as well as a data and analytics lead. So we do a lot of work with inequalities and population health management and trying to understand the population better, and then allow us to sort of work through interventions and how we evidence the impact of it. So we've been asked today to talk about what data we have got, and obviously we've heard a lot around what public health hold from Matt, and Gillian's alluded to what we've got from a PCM perspective. A lot of the data we've got is from a primary care perspective, so it's general practice as the sort of where registered patients are and where a lot of the data is held, and just at the moment we haven't got quite the access to the wider pieces of information, just from a sort of data sharing perspective. As Gillian has also said, these are early days. You know, even from a data perspective, we're only really starting to explore what we have got access to, how we use it differently. We're so used to being reactive that actually now we're trying to work a bit more preventively, and trying to understand the data we've got around that isn't quite the easiest. And as you'll see through the presentation as well, it's a lot around, we know what we know and we don't know what we don't know. So actually us all being here today helps us explore that further as well. So I tried to win with the least amount of slides, but Will definitely won that. So I've only got 4, but I have got a bit of a demonstration as well. So just in terms of, it doesn't work out quite that well, does it? Just in terms of actually the data and what we're trying to do with it. So it helps us understand the scale of the inequalities and mainly allows us to support targeted intervention. So a lot with population health management, there's 3 main things to sort of work by, and that's identification, intervention and impact. So my main role really is looking at the identification and how we evidence the impact of that. So one of the things we've recently done now is created and developed an interactive population health management tool. And really that's just designed in a way to summarize our data so it's easy to interpret and it's quite meaningful. And that's the bit that I'll go through. And part of it is to show you what we've got access to, just as a sort of general awareness piece, but also what we'll be looking to do in the future as well as make that available to you. And how do we put that in a public domain so that you've got access to it and it helps you target your populations and your communities. But like I said, it's only a primary care side of it and we don't know everything. So it doesn't give us all the answers. So it's only really one side of the coin. And hopefully what we'll work through today is how we understand those residents we don't know enough about. So the tool which we're just about to go through now, really it was designed to do 2 things. It's a strategic sort of tool, but really it's looking at testing out what we do know. So if we've got theories around obesity and deprivation and inactivity, what does that mean and who the patients are and where they're from? But also we can explore what we don't know. So we can start to see that actually we've got proportionally low numbers of patients in certain areas that we would expect a lot more to, and that means we can explore that further and investigate it more. So I'll show you the tool. And what we want to do really is just sort of take you through a couple of studies or case studies or examples of how we can use the tool. You can see how quickly we can get the information that we've got available to us. And then you can also then start to think of actually, if we had this, how would we do interventions and what would we do differently with it? So if I need it to work. So it's designed to be interactive. Let's try and get full screen. And it's not showing up. Oh. It's a bit hard there. Right, let's try that then. Oh no, I've got to look up there. That's going to be interesting. That was me. It's a lot easier with a mouse. Right. So obviously we've got a bit of an introduction page as to what it is and what it's designed to do, where the data is from and some of the caveats around it, but also what we've tried to do is apply some of the things within it. So we've got costs that are associated to so many patients, and that's the cost of admissions or cost of GP practice appointments. And so how it works is you quite literally just filter through the pages. So what you get is essentially the breakdown of a population. We haven't used every single indicator available. What we've tried to do is pick some of the most common themes and try to break it down in a way that means something to people. So just checking, can everyone hear me? Because every time I look up there, I can't. That's fine. So what we've got is it's broken down by the demographics of individuals, then you've got the long-term conditions, then you've kind of got the activity of a patient. So you're thinking of their health checks, what's their BMIs, do they smoke, alcohol units. You will interestingly see some data caveat issues. I find it very hard to believe that someone's had 14,172 alcohol units a week. That's quite a lot. I mean, we've probably all been there at one point, but that's a lot. So there are some things that we just need to find sort of finesse a bit more. And like I said, it is always in development and it will evolve as we go along. And I think the first iteration I started showing looks absolutely nothing like this. So it may completely change again. But the point being is that it's designed to sort of give you more and more information each time. And so we've got a bit of a summary page. It breaks it down to different sections. When you start to filter through to what you want to see, it will then allow you to keep that filter as you go into different pages. So we can start to see the common themes of those patients, the sort of how they're segmented, and I'll go into further what that means in a minute, and also where they're mapped out. So actually we can see from an LSOA perspective where those patients are based. So if we were going to start to apply a couple of things, and we wanted to see, so we'll start with patients of Hereford because we've built it across the whole ICS. So straight away we can see our registered population has gone down to 201,000 patients. We can see the total cost of those GP contacts for a year is £46 million. But what we can also see is the average GP contacts per patient is 6. Now, nationally, the average contacts of the GP practice each year is 5, which are looking for it to just be about to go up to 6. So actually, this is quite in line with what the national picture is seeing. So that would sort of also indicate, as we'll get onto a bit further on, that if you've got 4 or less, you're below average in terms of activity within a GP practice, which also sort of suggests that there's less engagement with that as well. We've included medication courses. Medication courses is an indicator for complexity. So the more medications you've got, the more complex an individual is. As a theory around that, obviously, sometimes you'll see that more patients have more medications, but not necessarily complex. But as a sort of general sort of tone, average age of our population is 45. And what we can see down the bottom here as well is how Herefordshire is split out across the deciles. So we've got a fairly sort of bell shape in terms of most of our patients are in an IMD decile of 5, and then we've got obviously proportionally lower ones on the sides of that there. So what we can then start to do is if we wanted to look at patients who didn't have diabetes, but had a BMI over 30, there you go. And then we wanted to see that they were in a deprived area of sort of 1 or 2. What we can see then is we've got nearly 3,000 patients who are potentially inactive and they have a BMI over 30, potentially pre-diabetic, and they're also in a deprived area, which means they might have less access to provisions or services. So what it allows us to do then is start to think around, well, okay, well, over the whole Herefordshire, have we got 3,000 patients here that may need an intervention? And it makes us then think about what we might do differently about those individuals. So what we can then start to do is filter through to see what the common themes are with those. Obviously, I'd expect to see the BMIs in there, but that's a bit lower down. So actually, of those patients, what we're also seeing then, we've got a high proportion who've got depression. So it's not something we looked at, but we can already see that actually nearly 900 of those patients are depressed. Now, is that a reason for their inactivity? Is it a reason why they're obese? Is it because they're in a deprived area? The thing with these tools is they don't necessarily give you the answers, but they allow you to explore what the answers could be. What we're also seeing then, and usually we see hypertension as a bit of a byproduct for most clinical conditions, but there obviously you've got hypertension, we've got a high proportion with asthma, and also nearly 20% of those smoke as well. So we can start to see what some of those trends are across the patients that we're seeing. What we can then do is look at the segmentation. Now, segmentation is a very sort of rough and ready way of trying to understand the impact that you can have with a patient or a resident or a citizen. And what it looks to do is it tries to factor in their complexity in terms of their long-term conditions. So you see the first column's got 0 to 1 long-term conditions, the last column's got 4 or more long-term conditions, and then it also then starts to break it down by the age categorizations on the left-hand side. Now, what you can see is, and I've been pulled up on this before, so as a slight rule of thumb, there's sort of more conditions, and the older the patient, the less impact you could potentially have, because they're a more complex patient. I'm not saying no impact, age doesn't necessarily factor into it, but as a sort of slight rule of thumb. So what this is suggesting is actually those patients that we're seeing at the moment that we think we can make an intervention with, the majority of those patients are between 18 and 65 and have got 0 to 1 long-term conditions. So we've got a population of patients that potentially we can make quite a high impact with, because we've got time and we can start to factor in the holistic and well-being ways of working around this. And it's more the socio-economic ways that we can start to think about how we make a difference. And that's just the sort of, you can play around with all of it. And then what you start to see is that actually, is there ways I can make an impact? Or am I seeing that I've got highly complex patients that's more difficult to work with? The other thing we can do then is start to look at the map. And so this works. Yeah, good. So as you remember, we chose the 2 most deprived areas. And obviously, as Matt had said, we haven't got a lot of deprived areas in our county. So the 2 main ones we've got are in Leinster and in Hereford City. And we can see there's a relatively even split between those 2. You might see slightly more. No. So what we've got is actually those 3,000. There's no sort of real trend between the fact that they're all in the north and west, or they're all in the city. We're seeing a relatively equal split. So I'd have thought it would be around 1,500 people per area. So that doesn't necessarily tell us anything, but it does tell us where our deprived areas are and where we can focus on. What you start to see is when you bring in other indicators, you can then see, if we took out deprivation and you take out deprivation, so take out that, you can see this map then spread out across the whole of Herefordshire, because we've now, our population across the whole of Herefordshire that aren't deprived but are BMI over 30 and no diabetes recorded is now 35,000. So you can start to see how that's spread. Oh God. Is not necessarily meaningful, but what it does start to let us know that that is the case, and that actually, you know, we've got something here that is place Herefordshire wide. What you will start to see with some of the things is that you only get pockets of it, and that's where it becomes particularly helpful as well. So if we looked at the ones then that were, so we can now see the lighter colours are the ones with less populations, and the dark colours are the ones without. Oh, this is Denmark, as you can see. Oh, right, okay. That was hard. As you can see, we have got slightly more denser populations with depression, no diabetes, and a BMI over 30. And around, actually, interestingly, around the rural sort of areas on the outskirts of our county, we're seeing that actually we've got less of those issues, and they're sort of more clustered towards south and west, east, and the city sort of side of things. So I'm just thinking from your perspective, from communities and voluntary sector, it's that, okay, well, if I know that I'm based in the north and west, and I've got a population of patients who, really do need some support with physical activity, then you know where to sort of focus that attention. And that's the sort of point of it, really. So that's the tool. I'm just conscious of time. So that's where we go with it. And obviously what we've got then is it, and like I said, we will try and make this available to everyone. And it just means then that you can start to filter through your own ways of working. And it may even be that we try and create a slightly different one, so it's more bespoke to you guys, that makes more sense. I'll just go back now then. So if I can start this original rule of getting this back on the screen again. So there we go. So one of the things I didn't quite touch on then is obviously one of the good examples that we found from the tool is that we can start to see where prevalence comes into it as well. So where we're expecting to see a higher proportion of patients in a more deprived area for things like anxiety or depression, stereotypically, I'm not saying that's strictly true, but what we are starting to see from the things of the tool is that actually those are proportionally lower. So we're seeing, hundreds instead of thousands of patients in the most deprived areas, and actually that sort of indicates that we're not engaging, or we're not being engaged with, everybody there and the people that we're expecting to be. And it also then allows us to think about how we might get to those patients differently, and talk community hubs and PCNs in terms of getting out into the communities. And then you guys, and really in terms of, okay, what data have you got? What are you seeing? Are we making sure that, just because we're not seeing them, are they being cared for, is where we're sort of trying to go with it. So just a couple of things just before we finish off. So I kind of touched on it slightly then, but what the data can't currently tell us is this is very much from a health perspective. So we only know the patients we know about. So we only are aware of those that are touching our services. And that's a big problem, because obviously that's where the whole inequalities things comes about, is that we don't know the people we aren't engaging with. And if they're not coming to us, then we need to go to them. It's very difficult. And I was trying to pick up on some of Matt's points in terms of the primary, secondary and tertiary prevention side of things. Obviously, because we know about it, we know that it's the tertiary side of it and potentially some of the secondary side of it, because it's happened. So we can certainly look at putting interventions of stopping things happen again. But what we need to work through is how do we get the data to support the primary prevention before it's happened. And that's where actually some of that stuff around non-diabetic with a high BMI in a deprived area that could potentially lead to diabetes is where we want to try and push that primary prevention in understanding that population better to get to them before they get diabetes. And then the last thing really is we don't know what's happening in our communities and across the voluntary sector. And I use we in the broader sense, but really I mean me. So I'm not, from a data analytics perspective and the stuff that we've got access to, we don't really know what's happening. So what we want to try and do is figure out how we can really bring that together and make the most of the data we've got access to and really paint the fullest picture. And so the last thing really is just, so what now? So I think we've seen from Matt's, with the understanding how to share information and what we've currently got from a primary care perspective, we've obviously got elements from secondary care as well. We probably know about 50% of what, of understanding our population. That massively factored in with what we don't know in terms of what we haven't got access to. So one of the things, well, Christine, hate me for this, I'd also like to consider on your tables, just as a bit of a plug, is what data do you have that would support understanding and identification of those populations that are exposed to inequalities? So start to think of questions around how do we bring the community insight on how to reach and engage with those suffering inequalities? How do we work together to bridge a gap in data? And how do we support you in ensuring that you have the information you need to target your communities? That's it. Thank you very much.